Anyway, good evening, everyone. Firstly, welcome to our first of hopefully many CPTV Academy events. And this tonight is going to be on the Pharmacy Contraception Service. Please, the session, as you may have noticed, will be recorded, and the recording is going to be put onto our CPTV webpage for future reference, and also for those that weren't able to attend tonight. The slides will not be shared. The slides are Claire's presenting. However, we will be creating a resources and guidelines page, which will be on our website in the coming days. Can I ask everyone to please put their name and email address in the chat box? And during the presentation, any questions, please just put them in the chat box as well. And we will try and respond at the end. If we don't have time, we will definitely respond to the questions afterwards. One request as well, for the flow of the training sessions, to please put yourself on mute. And that's from the introduction point of view. I'd just like to welcome Claire Holland. Claire joined us recently as a pharmacy trainer. And I've known Claire for many years, so Claire, welcome. And also to Ian Dumfrey. Ian is our LPC chair. Both Ian and Claire are both IPs and have a wealth of knowledge. So Claire, over to you.
Thank you very much. So I'm going to try and share my screen. So bear with me if this is a bit clunky at the start. So hopefully I've had a bit of practice at this, so I'm hoping that you can see. Kevin, give me a thumbs up. You can just see, you can't see my presenter notes or anything like that. Okay, awesome, thank you. So thank you so much for that really lovely introduction. My name is Claire, and I am, my background is in community pharmacy. Probably my heart is in community pharmacy, but I'm currently in GP land at the moment, selling statins for a living. As Kevin mentioned, I have recently completed my IP in lipid modification, and but I've always maintained my links with community pharmacy, and I'm really happy and delighted to be asked to help the Thames Valley LPC with any training events. As Kevin mentioned, this is the first one, so bear with us, bear with me. I will try and make it a bit interactive, but I know it's 7:30, it's a Thursday, it's a sunny evening, there's kids to be put to bed, there's lots of things to do, box sets to watch, so bear with us. Do give us feedback as well, so leave comments in the chat. I'm going to try and not look at the chat because I'm a magpie and I will get distracted, but pop things in the chat, and then if there's things that come along as we go in, and Kevin, if you throw it out there, that's absolutely fine if it fits in with what we're talking about. But as we said, we will put together a resources sheet, and the video will be available to watch. So that's enough about me. Let's get to what we're here for. So I thought, before we get into the clinical detail, and we've got quite a bit to cover this evening, I thought we'd warm up with a bit of a game about myth versus fact. So I'm going to read out some statements, and it would be great if you could just pop in the chat box myth or fact. So if you're feeling really bold, then unmute yourself and shout out. So here we go. First up, the progesterone-only pill must be taken at the exact same time every day. So I feel like we should have some Kahoot music going on in the background, but if you want to pop some chat in there. Are we getting any responses? I'm ignoring it. What have we got, Kevin? What's been the overriding?
Watch for the moment. There's no one there. No one's responded.
No one's answering. No one's been right. That's fine. I know people are out there, so that's absolutely fine. So yeah, with the progesterone pill, the timing window is really important.
Fact, yes, true.
Yeah, so we know this. We have a really short window with progesterone-only pills. With the traditional ones, we've got 3 hours. With desogestrel, we've got 12. Okay, so now we know what we need to do. Let's move on to the next one. So allowing us to click. So pharmacists can only supply contraception if the patient presents with a prescription. Fact or myth? Go for it. And let's pretend there's Kahoot music in the background.
It's really come up, lots of no's, myth.
Yeah. So that's a myth. We know it's a myth. We've now got PCS, so the Pharmacy Contraception Service, so we can initiate and continue supply under a PGD. And the last bit, to make sure everyone's still in the room, combined pill is suitable for everyone under the age of 50. How are we doing there? What are we saying? Truth?
No, no,
No, exactly.
myth,
So eligibility depends on medical history, risk factors, and clinical guidelines. So a bit of myth busting going on there, and that's part of our role as well. Thanks for getting involved, jumping in. We'll unpack some of these statements as we go through. I realise everyone comes to this training with different levels of expertise in it. Some of you might have done the mandatory training, some of you might already be up and running, and some of you might just be starting to think about it. And so we'll get into the aims and objectives in a second, but just try and the purpose really is to get you thinking about how the service works and how you can expand it in your pharmacy. So objectives, as we said, whether you started it, you're doing it already, or this is your first time, over the next sort of 50 minutes, I've ambitiously put, I'm hoping to make it a bit quicker. We're going to walk through the PCS, hopefully trying to help you gain a bit of confidence in the initiation and ongoing supply of oral contraception, and apply the faculty guidance to be able to support safe and confident decision making. Need to recognise our role in safeguarding, which is wove throughout the service spec, informed consent and delivering patient-centred care. Look at some tools and some training resources that we can use to deliver the service efficiently, and also look at some real world examples, so top tips from pharmacies that are already delivering it, or pharmacists that I've spoken to, that mean that we can hit the ground running with it. So we do want to try and keep it practical. Please do send in questions, and we will try and get them to the end. So let's get started. So what are we already doing in community pharmacy? What can we do? So we aren't just dispensing medications. We are providing accessible, confidential, expert-led contraception services that make a real difference in patients' lives and people's lives, the public lives. We know this is supported by Public Health England. So the most common forms of contraception that we are supplying are obviously the oral contraceptives. We've got the COC, and we've got the POP, the progesterone only. These options give patients greater flexibility in accessing contraception without the need for a GP appointment. But we've been in this game a long time. We were there originally with the provision of emergency contraception. So in terms of the conversations that we're having with our patients, we're used to doing this. So we, are there at the beginning with levonorgestrel, which we can use up to 72 hours after unprotected intercourse. And same with, more recently, although I don't think it is more recently, I think it's at least 10 years ago, the ulipristal acetate ELA1 came out, and that gave us a window of up to 120 hours after unprotected intercourse. And I guess the point is, some of these obviously can be bought over the counter, some of them we're used to supplying under local commission services, but we're used to doing this, we're used to having these conversations, and the PCS is just an extension of this. And as we know, emergency contraception is going to be built into the service from October 2025, which will be great and really make a lot more sense for the general public as well, and a lot more kind of synergistic supply. So if we're supplying the emergency contraception, we can offer our patients, when we're talking to them, something like a long-term contraceptive option that will mean that they don't then have to rely on EC at those times. We also stock in our shops. We've got the barrier method. So we've got condoms. Some pharmacies, some specialist pharmacies might have diaphragms. So again, we're used to having these conversations about STIs and sexual health. And that's an area that we need to be comfortable within the PCS about talking to, breaking down taboos, making it just part of the consultation. to put our patients at ease really, and signpost them and refer them to the sexual health clinics. So it's really important that we know, we make those links, or we begin to make those links with our local sexual health clinics. And within that as well, all conversations about contraception, NICE tell us that LARC, so the long-acting reversible contraceptives, are the gold standard. So we need to be building that into our consultations. And we've got a slide a bit later on talking about how we can do that quite naturally, how that will evolve. And also in these conversations, we're talking to patients about fertility. We are ensuring vulnerable patients have the right support and guidance. So we've got the knowledge, but we need to be able to maybe contextualize that for them, so that they know that the information they're getting is correct. So we're at the forefront of contraception access in England, and not to mention, doing this obviously takes a huge pressure off our GP colleagues. We're used to providing expert-led consultations, and this is just yet another one of those areas. And ultimately, we're helping patients make informed choices and decisions about their reproductive health. So the more we embrace these services, the more we strengthen our role and community pharmacy's role in public health. So it's an exciting journey to be on. So let's keep making a difference. As we're talking about contraception, and as I said before, a lot of this is around patient counselling and patient education, I thought it'd be helpful to kind of recap on the menstrual cycle, and a way of making that sound quite simple for patients. So how I would approach it would be to sort of say menstrual cycles are a natural, it's a monthly process that prepares the body for pregnancy, even if pregnancy isn't the main goal. Typical cycles are 28 days, although anywhere between 21 days and 35 days is normal. And again, that might not be known by everyone, and different individuals coming to the pharmacy might have different levels of knowledge about this, thinking that you might have some young girls and they're not sure. So again, our role around counselling is really important there. The cycle starts on the first day of your period, and that's when the uterine lining is being shed, and this is causing the bleeding. Around the middle of the cycle, so day 14, if you're lucky and you have a very steady cycle of 28 days, your body releases an egg from the ovary. That's called ovulation. If that egg isn't fertilized, then the hormone levels drop, and the body sheds the lining, and that's the next period. So throughout the whole cycle, we've got these hormones, estrogen, progesterone, rising and falling in the cycle, and they can impact on patients' mood, their energy levels, even their skin. Again, so you might be having these sort of opportunistic conversations at the counter about what's going on in people's lives. It's important to reassure them that people will feel different at different parts of their cycle, and helping with counselling, helping them understand how to manage their symptoms like PMS, and choose the right contraception would be really important. And we know this anyway from selling naproxen and things like that over the counter. Heavy bleeding, missed periods, or severe pain is really important to refer patients back to their GP or specialist. And again, tailoring that conversation is really important. As we said, we could have a younger audience coming into us, sometimes a gaggle of girls, a gaggle of teenagers, unsure, they're not sure. So keeping the language simple and friendly is really important here as well. Keeping it not too clinical, not too technical. We don't want to be overly scary. I would have a big word of caution here. So we know the service is available from the onset of periods. However, and we'll cover some of the safeguarding issues later on, but bear in mind, children under 13 and under can't consent to intercourse. So if we have a concern that a 13-year-old is coming and they want contraception because they're having intercourse, then that's a safeguarding issue, and we will cover that a bit later on. And again, it kind of underlines the point that actually the service is for contraception. So if someone comes in and tells us they want it for cycle control or skin, unless they're actually using it for contraception, that's the bit that we're allowed under the PGD. So just do bear that in mind. Okay, So, how do we do it? So, as I said, we're used to having these conversations. We're used to speaking to patients, interacting with them every day. We use a sort of consultation model, and I use it quite a lot in my role. It's the Calgary Cambridge. It just helps us structure that conversation. And really, what it's trying to do is draw out the patient's needs and trying to put them at the absolute forefront of this conversation. Um, the the model itself, we can use, it can be used face to face, it can be used on the telephone. I use it a lot on the telephone. And just bear in mind, the PGD does actually allow for remote consultation, so video or telephone. And again, a word of caution on that, just making sure you are really stringent on your confidentiality, making sure that's upheld, and there's guidance on how to carry out remote consultations, which I'm sure we're all familiar with. But it's just something to bear in mind. And actually, in terms of managing workflow, some pharmacists find it really helpful actually to do sort of a mix of the two. So maybe have a provisional telephone conversation with the patient and do a bit of pre-screening questionnaires before moving on to the full sort of counselling when the patient comes to collect their supply. This is really helpful in terms of freeing up time and kind of releasing you from to be able to concentrate on them in that consultation. So in the actual consultation itself, we're going to be warm, friendly, let the patient know that this is a confidential service, a confidential space. You're introducing yourself, your role, check you've got patient consent, confirm their identity to move on. And also bearing in mind that the patient's age, as we mentioned before. It's important to sort of say, like, again, it's a sensitive conversation, but I do need to ask you some questions just to make sure contraception is the safest, most appropriate option for you. So we'll talk through some of your options today, make sure everything's safe, make sure it's suitable for you. Patients might be nervous as well. So we might enter into scenarios as well where, as I said, you might have a gaggle of teenage girls appear, and you might have someone coming in with their parents. Some pharmacists that I've spoken to have found it really helpful to make sure the chaperoning policy is visible. So that if someone does want to have company with them, we can offer that. We'll cover it a little bit later on in a safeguarding scenario where perhaps we wouldn't want or have suspicions about somebody accompanying that person in the consultation. But in terms of putting the patient at ease, build in a bit of chit chat. Again, we do this anyway. I don't know how many times in community pharmacy I talked about the weather, but it's something just to kind of put that patient at ease. It's a human interaction, and we do like a moan about the weather. Bear in mind timekeeping, which is my massive flaw, but it takes about 20 minutes to do the initiation consultation. You can wrap up the continuation supply within about 10-15 minutes. But again, just helpful in terms of managing your workflow. And again, just try and, again, a bit of advice there was relax and enjoy the interaction. It's rare that we get to talk to well patients as well, so enjoy it. And I know that it is daunting, the amount of training that needs to do, but hopefully throughout the webinar you're going to pick up some helpful tips around building your own confidence and how to approach it in practice. So next we move on to gathering the information. So there's a pre-screening questionnaire that is really helpful that I found. Community Pharmacy England provide this. I'm not sure if anyone uses it in practice. Maybe shout out if you are, or pop in the chat box. Again, we'll share it on the resources page at the end. But again, this is our fact-finding bit. So this helps us gather the information. And it also means that we have this then before we enter into the consultation. So we've got a bit of time to build up our own knowledge about this patient before maybe we're actually speaking to them. And it can be given out maybe if that patient's a walk-in before you go and see them, let them fill it out. Or you can text it to them as well, if that's something that you've got going in the shop. And then we move on to looking at some of their observations. So we do need to check their blood pressure and BMI. So you can do that. And some pharmacists, again, it's a personal choice about how you like to carry out consultations. And some pharmacists, like the theatre, have been able to do it, and it feels to the patient like this is, you know, like the service that we get at the GPs. But you can do self-reported. So if that patient has come in with self-reported blood pressure, self-reported weight and height measurements, and you're, again, using your professional judgment, you're confident that that's accurate, then document it as self-reported. But we can use that. And then start to ask sort of open questions. So asking, have you used contraception before? If so, did you have any side effects, anything like breakthrough bleeding, difficulties remembering taking it? Keeping it patient-centered, we could also say, have you ever been advised not to have hormonal contraception due to a medical condition? Again, giving the patient a bit of time to tell us about what's going on with them. More relevant for continuation, but you could say any recent changes in your health that might affect your contraception use. And again, we're looking at maybe they started smoking, things like that. That would contraindicate the combined contraceptive. How's your experience been with the pill? Do you find it easy to take it? Do you take it at the same time every day? And then allow them a chance, and hopefully they say, yeah, no, it's fine. But if they're saying, oh, you know, here's my packet and I've missed 3 out of the last 7, and then that's a nice lead into the conversation around the LARC contraceptives, so the long-acting ones. And again, we'll cover that in a bit more detail. All of this, gathering the information and working out their clinical picture in the background, is supported by the FSRH guidelines. And wow, that's a big document. So I think that's about 176 pages. But a bit like the BNF, we don't know everything in the BNF, but we know where to look. So I'd suggest having a look at that, getting familiar with it, tabbing it on your consultation computer screen so you've got it to go there. It's a supportive document, and it's meant to help us in assessing medical conditions and risk factors and contraindications, but we're never going to keep it on our head. Health conditions, big ones that we need to think about: hypertension, migraines with aura, history of blood clots will rule out the combined oral contraceptive. We can then, though, we're not dismissing this patient. We can then offer them progesterone only if they want to stay within the PCS service, or again, we've got LARC, as we said before. The guidelines also cover topics like starting or restarting contraception after childbirth, and breastfeeding. And again, there's more detailed information and advice there. Generally, the POPs are considered more appropriate in terms of not suppressing estrogen can suppress the lactation. So that's generally the rule, but knowing where to look in those documents is really, really important. Being able to sort of research in them, so having them to hand is really helpful. And another area to think about, and it's beyond the scope of our presentation this evening, but do you think about carrying on contraception after miscarriage, and just the sensitivities and the tone that you might use in those consultations? Just have that in mind, that these are scenarios that you might encounter. We might have all the answers here tonight, but it's just to get your mind thinking about who might come in, who might pop into your pharmacy and ask for it. So on that, we do need to make sure that we exclude pregnancy. So again, just asking, is there a chance you might be pregnant? This is where our knowledge of the menstrual cycle is quite helpful as well, and because patients might know they may have had unprotected sex maybe early in the cycle, and that might limit their risk. But again, it's about being known or being aware. I've popped on nice clinical summaries, so the nice EKS scenarios, and we'll put this on the resource page, have really condensed information. Now, this is the information obviously that's used in general practice, so independent prescribers will use that, and some of that advice stretches beyond the scope of our PGD, so be wary of that. But it does have really good short, sharp summaries, user-friendly advice about the different methods that you can use, and explain things like missed pills, or how to start, like if you're switching between I was going to say devices, I don't necessarily mean devices, but methods, there we go. And also, like I said, maybe having those guidelines tabbed if you perhaps have a challenging situation where a patient is now not suitable for a COC, the weight has gone up, the BMI now throws that out, then having those guidelines in front of you, rather than having been able to show that to the patient as well, can sort of reinforce that guidance that we're trying to give, and just make them realize we're not trying to be really awkward. This is the same sort of level of detail and advice that you would get in your surgery. Need to look at their lifestyle. So we talked about BMI, and a raised BMI affects absorption, and so that's where we're looking towards the POPs. Smoking increases the risk of blood clots, and again, smoking's sort of on the rise in the younger age groups. So again, just being open about it and saying, do you smoke, is really important. And then thinking about medicines and their interactions. So asking patients if they're on medications, and checking their summary care record, but think about the enzyme inducing drugs. The big ones, rifampicin, probably not seeing much of that, but you might do. Carbamazepine is commonly prescribed for epilepsy, so somebody might be on that. And then herbal drugs. So some patients might choose to use something like St. John's wort to help with depression, low mood. They all speed up the metabolism of the contraceptives, though, and they make them less effective. So again, that's important. Then we're not leaving that patient with sort of no choice. We're sort of saying, well, actually, unfortunately, these options wouldn't be suitable, but I can direct you to the sexual health clinic, and they're able to offer you LARC. But obviously, having your own, this is where they are, these are their opening times. Having that kind of information is really, really helpful. So we talked about starting the relationship with a bit of rapport and chat about the weather and the day and how the patient's doing and all of that. Now we're going to really build it. And this is about exploring the patient's ideas, their concerns, their expectations. And a really good way to do that is by sending out, I don't know if you've used or you've had a look at Contraceptive Choices website, and also Brook have really good information and advice. They have questionnaires that patients can fill out that do a lot of this kind of heavy lifting for us in advance, so that the patient is coming into the consultation. So if you're able to text them this link before, or speak to them on the phone, advise them to have a look at this, or ask them if they're in your shop before you're going to have a chat with them, have a look at this website, have a look, and they are then coming to the consultation with a bit more knowledge than they might have done originally. And women talk to women, so this pill worked for me. You've got to be aware that some patients might come in with a mindset, and again, that's where having the guidance and to be able to have those conversations, if we're going to say, oh, actually, no, that's not the best choice. Trust is key. Think about body language, tone, and phrasing things to put patients at ease. We said already about a younger audience, they might be nervous, they might be scared. So having those kind of information ready for them, it is going to help hugely, so that they're not embarrassed as well. And then also just to say that the links for the contraceptive choices are also linked on in Pharma Outcomes as well. But again, if it was me, I'd have them tabbed as a bookmark, so I was able to send them out. Another thing to think about in the world that we live in now, and again, it's just about speaking to patients, all patients, with respect. Some patients might present and not identify as female, and think about how we might handle that scenario and situation. And I know Ian and I talked about this over the last week or so. Those patients do tend to come in with a bit of a preset idea. They tend to know quite a lot about it. We're definitely, in all of these consultations, we're there as a guide, but we're very much there as a guide and just making sure that the decision or their decision is safe. But again, treating that person just with respect and kindness, it runs through all our consultations anyway. So we're getting there. We're moving on to the explanation and planning part. So we want to share the suitable options. So I'll pop this on the resources page, but I found a really helpful video on CPPE. They did a 20-minute video. They've got a couple, two are an hour long each. There's a 20-minute video, and it really does make this kind of open world of the amount of contraceptives that we could supply seem much easier to understand. They in any PGDs we've had in the past, we've obviously had quite clear guidance. You know, this patient's this age, we give them this flu vaccine. They're this age, we give them this flu vaccine. This does feel quite daunting, because it's like, wow, we could give a whole host of medications here, and how we make that decision. And again, it's about that preparation for the patient, but also being aware that not every pill is available on the PGD. And so again, making sure your PGD is up to date and that you're staying up to date with the PGD is really important. So we counsel them on proper usage, on the mechanism of action, which we can touch on in a little bit. And the differences between the two, and again we'll go into that in a little while, but underlining really in this part, with the explanation planning, adherence is the key. So oral contraception is 99% effective if taken properly, and we know in the real world that doesn't necessarily happen. So making sure we're showing the patient the patient information leaflet, so that they know what to do if they've missed a pill. Using the NICKS guidelines can be really helpful there as well. And also then, you know, if they have missed the pill, to come back to us, and maybe we need to have a conversation about EHC. Checking the patient's understanding is really important here. So we use chunk and check in practice. So sometimes I might say, oh, you know, to check they've understood it right. So what did we say we were going to do? And that might be things around, say you were going to use the combined oral contraceptive, and we were discussing how they were going to take it. I mean, when I qualified, it was 21 days and a 7-day break, but obviously we've moved on from that now. So, you know, checking the patient, that we've understood what the patient has taken from our consultation as well. So that's that bit. Then we're closing the consultation. So summarising the plan. We're wrapping up with a bit of clarity and encouragement. So we want to encourage them to come back to us as well. So pre-book. So if you can, particularly on the initiation, remind them to book in. If you can use your booking systems, we talked about this before the call. We've got systems ready to go in terms of booking appointments. So if that's possible, but if not, remind that person to come back to you when they've still got about 2 weeks left of their medication, because again, we're open to all in pharmacy. We're the most accessible healthcare professionals on the high street. We can't do everything, and you know, we can't necessarily drop everything to be able to facilitate a walk in at 5 to 6. So try and explain that to the patient as well. Tell them what to do. So manage their expectations around side effects. So particularly with the initiation patients, but with all patients really, side effects. If you're starting a pill for the first time, we don't know. Patients might react differently, and not every pill suits everyone. So don't be disheartened either if the patient comes back and tells you, no, I've had breakthrough bleeding, this is a nuisance, my mood has dropped, I feel rubbish. Sometimes the combined pill can be associated with headaches and nausea, generally mild, but they can affect people's adherence and put them off. So I think encouraging them to come back so we can talk about alternative formulations is important, whether that's a redirect towards the POP, or looking at alternative methods. And again, that's about singing about the larks, really. And obviously, then in closing the consultation, that's where it's over to us to do all the documenting and making sure everything goes through in pharma outcomes. I'm not going to spend long on this because I'm really conscious of time, and we've got lots of other things to talk about. But there's a lot of misinformation sometimes spread by social media. And again, this is our role in education and counselling. And this might be a way of linking the service into patients. So if someone said, oh, I've had the pill cause infertility, no, it's not true. And actually fertility returns really quickly, or can do for some people on stopping contraception. So we need to make them aware that they could be at risk of an unplanned pregnancy. Needing to take a break from the pill. No, not necessary. And again, we can talk about the back-to-back methods, or have a look at that video on CPPE, which I'll pop up later on the resources page. STI prevention on the pill? No, I'm not sure anyone really believes that, but we should be encouraging that kind of dual protection if we're concerned about a person and their relationships, or they have relationships with lots of people. STI direction on STI clinics there is really important. And a big one, and again, we'll hopefully have a webinar on this closer to the time, but emergency contraception is the same as abortion. It's not. It prevents pregnancy. It doesn't terminate an existing one. But again, that's part of our conversation. The reason I popped on this was it is relevant. So it's more and more patients are at risk of pregnancy in certain age ranges, rise of social media, TikTok, this sort of negative messaging around hormones and a fear around hormones. So we're there to try and quash some of those and really hold on to the kind of clinical evidence that we can stand by. This hormonophobia trend is sort of creeping in and causing more anxiety in young people. So again, it's just really I wanted to keep it there to highlight our role in helping patients use fact-based, evidence-based medicine, but also how, if we are met with a conversation like this, how we can maybe weave that into sort of saying, no, but look, this is the service that we have, and this is what we're able to offer. Okay, so STIs, as I said. So contraception's not just about pregnancy prevention. It's all about sexual health. So encouraging dual protection is important. Signposting to STI testing is really important. And again, knowing where that is, knowing who your local sexual health provider is. HPV and cervical health. Again, there's been a change recently to the recall on cervical screening. So it's being aware of that, being able to explain that to patients. And obviously we've got safeguarding underpinning everything. These conversations can be sensitive, but they are important for holistic patient care, and we can sort of weave them in naturally into the conversation, and we can look at ways of doing that later when we look at some scenarios. Well, actually, we've got some bits on it now. So just normalising those STI conversations. So reducing stigma and supporting public health generally. So we could say things like, say, for example, it's a patient who's in a healthy, normal relationship, and so this could seem a bit awkward and why we're coming up for it. So why we're mentioning it, so we can say things like, just so you know, pill doesn't always doesn't protect against STIs, or we always offer this sort of information about local health services or local sexual health services, in case you ever want to get tested or you have any questions. And again, if you're really techy, and I'm not, but you can have QR codes with the links, and you can also direct them to the NHS STI testing services website. And again, I'll pop that on the resources page. You could also mention if your pharmacy offers the condoms or chlamydia screening tests. I'm not 100% certain on that, and I'm going to direct you to Kevin if you've got any, if we're still doing that locally, I'm not sure. But we did have it in my community pharmacy years ago, and I'm not sure if it's still running, but I'll leave that to the support officer. I've left this in. This is, I'm sure everyone's got a really good background knowledge on Gillett competence and Fraser guidelines, but I have left it in anyway, mainly because I worked really hard to make this slide all line up. But Gillett competence is so Gillett competence and Fraser guidelines relate to any patients that we might have under the age of 16. Gillett competence relates to general medicine, so making sure that anyone under the age of 16 is able to understand, has maturity and understanding to consent to their own healthcare decisions without parental involvement. Fraser guidelines, they're more specific, and they are related to advice about sexual health. And it allows us as healthcare professionals or anyone using the Fraser guidelines to be able to determine whether we are able to supply contraception to a young person, ensuring it's in their best interest. So I won't labour the point too long, but let's look at it from a scenario point of view. So I've cut this straight out of Farm Outcomes. But say, for example, we have a 14-year-old girl, and she's gone, hey, I want to know about the contraception pill, but I don't want my parents to know. So what are we going to do? So first of all, we want to put her at ease. So we're going to say, thanks for coming in. Before we go on, obviously you're in a confidential area in the pharmacy to be able to say this. I need to check whether you fully understand your decision and make sure that option is okay for you. And then give them a moment to be able to respond. And assuming they say yes, we should then go on to say, look, I want you to know this is a confidential service. It means that I won't share anything that you tell me today unless I'm worried about some harm that might come to you or someone else. Again, check, is that okay? And then say, I have to ask you some questions. And it's really just to make sure we're getting the right contraceptive option for you. You don't have to answer anything that you don't feel comfortable with, and you can stop the consultation at any time. So again, this is putting our patient as their as the priority, and it's allowing us to assess their maturity and understanding. So then we need to look at their relationship. So asking, are you currently in a relationship? Can you tell me why you want to use contraception? Do you understand how the pill works? Looking at including the benefits and the risks. We can look at that a bit later. Have you thought about alternative options? And do you understand what to do if you've missed the pill? If they're GILEC competent, they've shown sufficient understanding, then we can proceed without parental involvement. The Fraser guidelines are more specific, so that, again, checking they understand the nature and implications of contraception. We can't persuade them to tell their parents. So again, we need to check, would they be prepared to tell their mom or dad or the guardian, whoever they live with. We have concerns that their mental or physical health would suffer without it. So the provision really would be in their best interest. If all that criteria is met, we can continue delivering the service confidentially. What happens though if we are worried about that patient, if we're worried about coercion, we're worried about exploitation or abuse? This is where our local safeguarding protocols come into place, and we need to make sure we know them, that that we have them live, that they're up to date, we know where to access them. Safeguarding is a core responsibility for all pharmacy professionals, not only just delivering PCS, but we do have the short child sexual exploitation questionnaire built into Pharm outcomes that we need to go through for patients under the age of 18. And I won't read through the questions, you can see them all on the screen, and you know them probably from Pharm outcomes anyway, but just be sensitive again about how you're asking these questions, because they might be sort of not keen to answer, and thank them for their response and say, look, just trying to make sure that everything is safe and respectful in your relationship, and so also remind them that if things change, if things don't feel right, you are a trusted adult that they can come back to and have that conversation, and again we can raise on their behalf a safeguarding if we need to. Looking at signs of abuse and coercion, particularly vulnerable individuals can show unusual behaviour or signs of distress, signs of grooming. If a person lacks capacity to consent, we cannot supply the service. And this is where our level 3 training comes in, to be able to spot the signs of abuse, how to raise a safeguarding. Essentially, it is so important we document everything, and the local protocols are followed. So knowing who they are, what they are, who you need to escalate it to before the critical moment would be really important. I'm really conscious of time, so I am going to whiz into a quick scenario. And again, a slide I spent a bit of time on. So on the one column, we've got the red flags, we've got how we might deal with it, and then the next steps. So in this case, we've got a 17-year-old who's come along to the pharmacy, and they've come with an older adult. This older adult could be a parent, could be a partner, just for your own kind of thought, about scenarios that might arise. And they're asking about contraception. She appears withdrawn, she's avoiding eye contact, and the accompanying adult is doing all of the talking, so they're doing all the answering of the questions and interrupting our patient that we're trying to talk to. So, and then when the pharmacist asks that person to leave, they become agitated. So our red flags are patients not communicating freely. Their accompanying adult is dominating the consultation. So we are worried then that we've got a concern about coercion and possibly lack of capacity due to undue influence. what are we going to do? So we can politely but firmly suggest that that we need to have this consultation alone. So before we begin, I'd like to have a quick chat with whoever. It's standard for this type of consultation. Do you mind waiting outside? I'll come and get you as soon as as soon as we're finished. We're probably going to get pushed back, but it's important to say, like, it's just a routine part of the service. It helps us support X, Y, Z, whatever they're called, in the best way. If we manage to get that person alone, then it's important to sort of reassure them that this is their space, everything that they discuss is confidential, and it's okay to have questions or feel unsure, but we're there to support. This is reinforcing our professional boundaries, upholding the Fraser guidelines. And then in the blue column, then we look at what we do next, and ultimately that is documenting everything and flagging to the local safeguarding team. And this sort of, it highlights the importance of having the information, as we said, about safeguarding ready to go if such a scenario arises. So we talked about all the things that can go wrong. Let's try and go through some scenarios where it's nice and straightforward. So a textbook example, we've got a 24-year-old woman. She's recently become sexually active. She can't get a GP appointment, so she's come to us. She saw a poster in our pharmacy, so that's great. When a patient presents for the first time, either after a break or having not had it before, we're in the initiation phase. This method is new to the patient, so our primary responsibility is to establish their understanding and ensure the method's safe for them. So we want to say, thanks for coming in. It's great you're thinking about contraception. Let's explore what works for you. As I said, we do the chit chat bit. We could have prepared that patient sending out the questionnaire beforehand. We're going to look at their brief medical history, BMI, blood pressure, talking to them about the fact that there's a few different types of pills and what might suit them. So some people like a regular monthly bleed, others don't mind if it's irregular, what's important to you. And again, that helps with the shared decision making. Luckily, in this scenario, we don't have any contraindications. And so she's suitable for the combined oral contraceptive. Again, being familiar with local formularies is really important here. So I would have a look. I would encourage you to look at your own formulary and see what's green in terms of COC, and have kind of a pre-prepared idea of how you would manage that consultation. But another thing I was thinking of, that you have a massive advantage over us in GP practice. You know what's in stock, so you have the ability to be able to tailor that consultation as well. Because it's awful if we send someone out and they can't get contraception, and they're worried about it. They're worried they're going to miss the pill, and the impending consequences of that. As I said, you look at the CPP video, the 20-minute video about making those choices and the level of hormones which may suit different people. Again, we're going to counsel about how the pill works, what to do if they've missed a pill. That's a conversation we should have up front. And their whole purpose is to build trust with the patient, empower the patient, and finally wrapping up with outlining that it doesn't protect against STIs. So recommending condoms could be appropriate in this situation. We're able to give her 3 months under the PGD because it's an initiation. We're going to send her out. We're going to show her the information leaflet, and we're going to send her out hopefully with a reminder card. And we're going to then busily document everything on Farm Outcomes, and we're going to have booked her in so she comes in 3 months' time, and then she can have her ongoing supply. This again is just about how to take the combined oral contraceptive versus when I qualified it was 21 days and 7-day break. We've moved on. We now know it's just as safe to carry on taking it back to back if that's what suits you. And I guess spend a bit of time look at this on NICE CKS. But in terms of what we're saying to patients, it's important to say you're in control. So there's no right or wrong way. So actually, if you try the traditional method and you're not liking it, you've got a holiday coming up, then going back to back, that's absolutely fine. We've got flexibility in that. And our role again is just to support around information and advice. This is the ongoing supply of the contraceptive. Not going to spend too much time on this because we have covered this already. But again, this is straightforward. We're going through the same consultation process, and we're able to. The main point about continuation is checking for changes in their health since they'd first picked up their prescription. So asking targeted questions about the medical history, lifestyle shifts, changes in weight, if they decided to start smoking, things like that, and that might then influence the decision. And then we've got, why would we choose the POP? So these are scenarios where we're there to be able to offer both options, but patients that maybe have estrogen sensitivity or contraindications like migraine with aura, hypertension, venous thromboembolism, so clot, background of clot, patients over 35 and smoking would be better advised to use the POP. Talked about it a bit earlier, but pregnancy, breastfeeding, and maybe after early miscarriage, and patients wanting to restart contraception after that. And those who just generally want a lower, maybe those patients that come in with a bit of misinformation about hormonal load and hormonophobia. Obviously, the POPs have one hormone in them, so they have a lower systemic hormonal load, and obviously fewer estrogen side effects, so less nausea, breast tenderness, fluid retention, means that some patients might find that a more acceptable alternative. In terms of structuring the consultation, review the history in the way that we would normally, exclude pregnancy and contraindications. The POP consultations require a bit more emphasis on the critical timing of the dose. So making sure that they know that they have to take it continuously every day, no pill-free break, and this expectation around irregular bleeding. So some patients might have lighter periods, some might have no periods at all or irregular spotting. Again, it's all normal, but let them know that we're there. If they've got concerns, they can ring us and we'll be able to guide them on what to do next. So this was a really quick slide about supplying the progesterone-only pill. And in this case, we chose something like Cerazette. So in this scenario, the patient, the pharmacist is checking any changes in your health, any side effects since your last supply. So check if that is really suiting them. And again, this just shows how this should be nice and simple for us, actually. It's an ongoing supply. So we could have tabbed that prescription. It could have come to us originally from general practice, and it's come into our pharmacy and it's been labelled up, and then our dispensers have noticed, well, actually, that's continuation. So we can then have that conversation and bolt that on. They're coming back to us then for the supply. And that's where we can take that workload off of our GPs and pressure from them, but maintaining, a safe supply of medication in the meantime. Switching. So switching can happen between all sorts of forms of contraception. In this scenario, we looked at the depot and moving from the depot over to the progesterone-only pill. The patients can want to switch for different reasons. Maybe they want to have slightly, they've used the long-acting, they want to have a little bit more control themselves about, maybe they're considering coming off contraception, but they're not quite there yet, and they want to have that flexibility. Again, looking at NICE-EKS for more detailed evidence on this, but switching from the injection, the thing to remember with the injection over to the POP, if their last injection was less than 14 weeks ago, we can advise the patient that they're covered. If it's greater than 14 weeks ago, then we need to look into excluding pregnancy because the protection might have worn off. And again, I would consult NICE-EKS on the details of the guidelines on what we do in terms of pregnancy exclusion and where we go next with that. So LARCs, so do we know our IUDs from our IUS? I didn't. So I had to spend a bit of time looking into that. But we know it's gold standard to have this sort of conversation with patients. And the reasons that LARCs are considered gold standard is their success rate is over 99%. Unlike daily pills, they don't rely on user adherence, which means they're less prone to failure due to missed doses. They've got a long duration of action, so they can last from 3 months to 10 years. So they're a really good choice for patients that want this kind of fit and forget approach to fertility. But it's really important to tell patients. I think the fear is, oh, I'm going to lose my fertility after this. It does return, it's reversible, it comes back after the lock is removed. And that might be important for younger patients who haven't yet had a family and would like to have a family in the future. Obviously, we're not fitting locks in community pharmacy, but again, it goes to our role as signposters to the sexual health clinics or GP surgeries who offer it. And remember, the main candidates who are most appropriate for these are patients on enzyme inducing drugs. So, and the key one there, obviously, most of these patients hopefully have been caught, but any females on sodium valproate really have to be on a lock. This was just about how we weave this into conversation, the consultation about a conversation about larks. I think we've sort of gone into this before, but looking at, maybe you've got somebody that's young and they've not thought about it before, and saying there's no one size fits all with different methods. The lark is this sort of fit and forget, and your fertility returns is another way of kind of weaving that into consultation. Or if that patient's got side effects and the bleeding is bothering them, again, we can advise them about the importance of lark. Or they've been using they've been using their pill for a long time, and this is their continuation supply, and they're obviously thinking longer term. They're not thinking about planning a family. This might be a more convenient option. So consultation tips. I would know your PGD inside out. You won't know every single detail on it, but you'll know the exclusion, the inclusion criteria, where to go, where to look. I would really make use of those shared decision tools that empower the patient, so they're coming in ready to the consultation. So contraception choices or the BRIC website were great. Safeguarding. So having an awareness of safeguarding, particularly around the age of patients that might present in the pharmacy, knowing those guidelines, knowing the Fraser guidelines, and having your safeguarding information up to date. And bookmarking this information, so having it on your consultation PC or dispensary PC, so you can look at it as and when you need it. I think I had anything else. Oh, gone too far. Okay. So boosting engagement. So use your whole team. So we're used to doing this with whatever service we are providing, but make sure everyone in that works in the pharmacy knows about it, knows how to book in for it, and is able to talk to patients about it. Whether that's HCAs handing out the prescriptions, or right down to dispensers being able to. I think we talk about it later. Yeah, PMRs, checking your PMR, having those prescriptions that. And maybe we're initiation to sort of say, oh, look, we can take, you don't need to go back to your doctor to order that. We can sort that out, and so provide your continuation, and it's a safe ongoing supply, and really trying to manage the workflow. So we said about this before, using the booking systems that we've already got to be able to manage that, because we can't drop everything and we're not always available. As much as we are visible, we are really busy in our roles. So using the workflow systems that we've got. Promotion. So CPE again have bag stuffers, pamphlets, leaflets, stickers. Make sure they're not too tired, sunny. Our point of sale stuff can look a bit tired sometimes, or some bleach. So making sure that it's impactful. I know there's not a national campaign around it, and I think that's because Pharmacy First took a lot of the emphasis was on getting Pharmacy First going from a national perspective, but do what we can locally, advertise the booking system. And the next bit was about collaborating with local GPs. And I know some GPs have lock, stock, said, okay, handing patients over to community pharmacy, which is great. But I think if you are worried about it and you're concerned that we want to do it well, the most important thing is that if we're doing this, we are delivering a service and we're delivering it well. It would be horrendous to overpromise and underdeliver. So start building with the continuation supply. Get your confidence up, because you will get weird curveballs, and it's about having those resources that you're able to tap into, tools in your toolkit to go, Okay, I don't know the answer to this, but I'll have to have a quick look. It's the same when we get wacky doses sometimes in dispensing. We have to go and look and sense check it, and things change as well. Things evolve, guidelines change, formulations change. So thinking about that, but I would definitely then go to your GPs once you've got that. Once you know you've got your confidence up and you're able to do it, you know how it's going to fit into your work stream, and really then sell it, and they will be delighted to be able to move that across to pharmacy. And then operational tips. So staying current. So attending webinars like this, thank you all for staying with us. But doing this kind of thing, looking at the CPPE website and NHS e-learning modules, subscribing to our newsletter, looking for any updates and training that we're providing as well. And we're hoping to run some future events focusing on women's health specifically. But staying relevant. And I would definitely encourage everyone to listen to that 20-minute video, because it's hard to find time, but 20 minutes you can definitely do, and you can put it on 1.5 speed, so you can make it a bit shorter. And then finally, with everything, document it, keep clear records, particularly of consent, making sure your farm outcomes is you put everything on farm outcomes and know what to do with safeguarding concerns. So finally, it's all about empowering patients, reducing barriers, and delivering high quality patient-centred care. So with the right tools, mindset and collaboration, we can make a real difference in people's lives. I hope over the last hour you've picked up some practical tips and tools, and you've got a bit of confidence and a bit of energy and want to go out and really deliver it with sort of compassion and clinical confidence. We really value your feedback. As I said, this is new for us as Thames Valley LPC Pharmacy Academy. So we'd love to be able to tailor these sessions. So if you found it helpful, great. If you think there's things that we can do better, please pop it in the chat box now, or email us. And I've put speak to Kevin. I've put Kevin's email address on the next slide, and we hope to see you all again soon. But that's everything from me. Thanks for listening, and I'll hand you back to Kevin.
Yeah, many thanks. That was fantastic. Really most enjoyable. Just a couple of things just to pick up from what Claire had mentioned. When you have to maybe refer someone to a LARC signpost, if you've done the consultation, that is still claimable.
Yes.
So then so you've done the work, you need to claim it, please.
Yeah. And also you can claim it if you don't make a supply. So no supply is claimable as well. So if you've had that consultation, and as I said, our role is so much around educating and empowering patients. So if we've decided, look, actually this isn't appropriate, whether we've directed them to a LARC or they've made another decision, we've done the hard work, we've had the consultation, we've provided that advice. So do claim it. Make sure, I'm stepping on Kevin's toes here, but make sure your what's it called, shared manager is up to date. So when patients are searching on NHS websites, that it's showing that your services manager is up to date. Is that the right thing?
Your NHS service manager. Yeah.
There we go.
Yeah. Okay. Just the other thing Claire mentioned, which is most important, is close to my heart, is in terms of keeping clear records. Yes, you do need to have clear records from a patient care point of view, but financially to monitor what the MYS, your claim is at the end of the month. So many pharmacy manager owners just accept what the NHS BSA has sent them. Please have your clear records to use that as a guideline to make sure that you have been allocated the correct amount of consultations and you are claiming the correct amount within time. That's most important. And then just lastly, is just to thank Claire for a great event, and supported by Ian, many thanks. And just please, this is the first of many. We will be doing many more events going forward. And also to highlight, we hopefully, at the beginning of November, having a women's health event in High Wycombe, which will tie in nicely with the launch of EHC within community pharmacy. So many thanks, and thanks to everyone, and have a great evening.
Thank you.